Both diseases consist of alternating periods of flare-up, or what we call exacerbations, where the disease is really active, and then times of remission, where the disease is under control. The time each person spends in both states really varies. Some patients can be in remission for years and years before ever entering into a flare-up, whereas other people might kind of always be in a period of at least like a mild flare-up, sometimes severe flare-ups, and really have a hard time getting the disease under control. So it's highly individual based on the patient's disease progression. So in terms of remission, which is where the disease is pretty well controlled, we have kind of 4 levels of remission. The most basic level of remission is called clinical remission. And this is where the patient's free from any symptoms of their IBD. The next tier of remission would be considered biochemical remission. So that's even better to be in than clinical remission, because biochemical remission shows that based on lab markers of inflammation, that the inflammation is well controlled. The next ideal type of remission that a patient would get to is considered endoscopic remission, which is when the gastroenterologists go in with a scope, say like a colonoscopy, they don't visually see any signs of inflammation. Then the final tier of remission, which is kind of the gold standard, although some patients may actually never reach this level of remission, is called histologic remission. And this level of remission is when they do a scope, so an endoscopy, they take a biopsy. And when they visualize a biopsy, they don't actually see any signs of inflammation at the cellular level. So any patient, if they're in remission, might be in any of these types of remission. Ideally, the best one to be in is histologic. But again, some patients may actually never reach that level of remission. I do want to mention that both types of diseases, Crohn's and colitis, can be very debilitating diseases, as they can significantly impact symptoms and quality of life. I would say probably about a quarter to a third of my patients are on medical leave or disability, and they can't actually physically work because it really impacts how they can go about daily life. Okay, so that's the types of remission. Next, we're going to cover both diseases, looking at where it is in the bowel and how much of the bowel it affects. So for Crohn's disease can affect any part of the GI tract from the mouth to the anus, but it does most often affect the ileum and the beginning of the colon. However, it can also impact the small bowel, but most commonly it affects the ileum and the colon. Whereas ulcerative colitis just occurs in the large intestine and the rectum. So ulcerative colitis, in terms of how it appears in the bowel, so what happens is there's usually inflamed or damaged areas of tissue that are patchy next to areas of healthy tissue. So I'm just going to jump forward to this next slide so you can see that on the left. The dark red is those inflamed areas. The light red is healthy areas of tissue. So it's a patchy disease. Whereas ulcerative colitis is a continuous disease. Starts at the rectum, spreads upwards, and then can spread to the whole colon if the disease is very severe. In terms of the extent of the bowel wall affected, in Crohn's disease, the disease does reach through multiple layers of the GI tract, whereas in ulcerative colitis, inflammation is only present in the very innermost lining of the bowel. So in this picture, you can see a difference. Middle is Crohn's, on the right is ulcerative colitis. So for Crohn's, because the inflammation does extend through all layers of the bowel wall, this can lead to very significant inflammation and thickening of the bowel wall, which you can see here. So the bowel wall is very thick, which leads to a narrow lumen, or the inside of the bowel wall. So because of this narrowing, that can lead to different types of complications, which we'll touch on a little bit later in our presentation. For colitis on the right-hand side there, you see that it only affects the innermost lining. There's some ulceration there, but because it doesn't extend through all walls of the bowel layer, the bowel wall, there isn't that same thickening and narrowing of the bowel. All right, so how is IBD diagnosed. So first of all, touching on blood tests. So blood tests are normally done to support a diagnosis, but right now they can't be used alone to diagnose. Some things that might be tested blood work wise that might kind of have a red flag for potentially wanting to investigate IBD would be things, or not necessarily specific to IBD, but can go alongside with IBD, are things like anemia or high white blood cell count. Also in IBD, CRP, which stands for C-reactive protein, that is usually elevated if there's inflammation. However, as you may have already learned from another lecture, CRP is not specific to the bowel. So it could indicate inflammation anywhere in the body, not just for IBD. Also, other blood tests that might be abnormal are electrolytes, especially if someone's having significant diarrhea or outputs, as well as LFTs, so liver function tests. Those can be altered in IBD. Some patients with IBD also have a genetic predisposition to liver issues. So other than blood tests, other tests that are often done in IBD, if someone presents with a lot of symptoms, say like bloody diarrhea, will be things like they do a fecal stool test to just rule out whether their symptoms are related to a bacteria, virus, or parasite infection. Based on these things, if they're abnormal, a gastroenterologist might go ahead and do an endoscopy. So usually a sigmoidoscopy or a colonoscopy. So sigmoidoscopy only reaches up to the sigmoid, so just the bottom part of the bowel, whereas a colonoscopy can visualize the whole part of the colon. Further testing beyond this may involve things like CTs, X-rays, MREs or MR interrographies, or ultrasounds. These would be primarily done in the small intestine to visualize that, because scopes generally have a hard time reaching the small intestine. So that's where these scans and other tests really come in handy to visualize if there's small bowel inflammation. Another test that is sometimes done is a stool test called a fecal calprotectin test. And this stool test measures inflammation in the bowel. Which is better than just measuring CRP because fecal calprotectin is specific to inflammation in the gut, whereas CRP, like I mentioned, measures inflammation throughout the body. Right now, just because of like what the healthcare system covers, they're not used to diagnose IBD at this point in time, but they likely will be soon. They're more for following up once someone has IBD to kind of assess their inflammation on a routine basis. All right, so I might just do a quick pause after these things. Are there any questions so far that anyone has?
I was just wondering if dietitians diagnose IBD or if that's something that doctors do.
Yeah, no, that's definitely a good question. So I would say that sometimes dietitians who are seeing GI patients, when they're assessing patients and asking about things like bowel routine, whether there's blood present, there might be some kind of red flags and things that the patient brings up that I would say a dietitian then would probably bring to a gastroenterologist's attention or refer a patient to a gastroenterologist to assess. So we can't, I guess, dietitians alone from what we gather from a patient, we can't say, oh, this person has IBD, but there can certainly be red flags that would warrant you to try to get the patient follow up with getting some testing done, whether that's starting with like blood work or seeing a gastroenterologist to eventually get a scope and things. So I'd say some like red flags for sure. If I'm assessing like a GI patient who comes in with, altered bowel things, you would want to be asking about if they're having any like blood in their stool. That's a big one. Nocturnal stooling, so waking up in the night to have bowel movements, that is not a normal thing. So that can be sometimes a red flag and cue that they might have IBD. Family history of IBD, that's another thing that it does. If you have a family member with it, that increases your chances of having it. And then if you have any things like if the patient's having like really significant weight loss and very severe symptoms, that also might be a sign that you certainly want to investigate IBD. Certainly all those things could be related to other things, like maybe the patient has like celiac disease or bowel cancer. There's certainly other causes of those potential symptoms, but those might be things that you'd want to investigate further if any of those symptoms are ones that the patient brings up.
Okay, awesome. Thank you.
No worries. Any other questions at this time? All right, so I guess we'll just dive into the next part then. So how common is it? So it's actually pretty common IBD. Around like 270,000 Canadians are currently living with IBD. And we can see that the prevalence has significantly increased over time, particularly in the Northern Hemisphere. And I'm just wondering, does anyone have any idea of why IBD rates might be increasing worldwide over the years? So feel free to unmute yourself if any of you have ideas about why IBD rates might be increasing.
This isn't like, I don't know, but like aren't all autoimmune diseases increasing in the last like 50, 60 years?
Yeah, no, as far as I'm aware, there's definitely a trend with a lot of different diseases, not only IBD. That's certainly right. Yeah. So I mean, there's certainly a lot of theories behind it. It's not known exactly why, but some theories are that there's a change in diet towards a more westernized type diet. Also, rise in antibiotic use could be a contributor because there is a link between the health of the gut microbiota and IBD. There's also the hygiene hypothesis. So as we're getting more like doing more sanitization and using hand sanitizer and those things, that does impact our bacterial composition of our gut. So that might play into the increasing rate. So I'm curious about how COVID will impact things now that we're all in a routine of, sanitizing our hands a lot and cleaning a lot. I think that could definitely have like an impact with autoimmune diseases in the longer term. I guess we'll find out. And then we do also have better ways of finding IBD. So I think there's more routine testing going on, we have better ways of finding it. Also, something to kind of point out that's interesting is you can see that in the Northern Hemisphere, like I mentioned, rates are higher than the Southern Hemisphere. That could be certainly related to things like the westernized diet, but another theory is vitamin D status. So individuals in the Northern Hemisphere generally have lower vitamin D levels, especially if they're not supplementing with vitamin D. And there does seem to be a correlation between patients with IBD having low vitamin D levels. Not exactly clear whether like low vitamin D levels can lead to IBD or whether it's when you have IBD, those levels are then like decreased, but there's certainly a link between those things. So that's one theory of the differing rates between the Northern and Southern Hemisphere. All right. So what causes IBD? So essentially, it's suspected that environmental factors in genetically susceptible individuals causes the immune system to malfunction. The immune system then goes on to attack healthy tissue in the digestive system, leading to inflammation. And beyond this, research has shown, like I mentioned, that there is an alteration in function of the gut microbiota in IBD, but it is unclear at this time whether the altered gut microbiota leads to IBD or is it a potential cause of IBD, or if the IBD then actually causes an alteration of the gut microbiome. So it's kind of a chicken and egg situation, not exactly sure which came first, but a lot of patients with IBD have a very abnormal gut microbiota composition. From a dietary perspective, it seems like certain dietary patterns have been associated with an increased risk of IBD. But right now, it's just an association, not a direct causation. Things that have been associated with an increased risk of IBD are higher intake of fat, particularly saturated fat, trans fat, omega-6, as well as meats and possibly sugar. Things that have been associated with a lower risk of IBD are higher intake of fruits, veggies, fiber, vitamin D, and zinc. So a lot of patients ask me, can IBD be cured? So the short answer is unfortunately no, because it is a lifelong autoimmune disease that does go in periods of remission and flare up. However, medication, sometimes surgery, diet, as well as other lifestyle factors can control the disease and symptoms and impact how long someone's in remission for. There is a little bit of an exception to this straight answer of no, which we'll cover in a little bit. And it's around potential surgical cures for colitis. But yeah, we'll talk about that in a little bit. But generally, we say no, it can't be cured, the disease. All right, so next I'll dive into the symptoms of IBD. So maybe first I'll go over colitis. So for ulcerative colitis, some of the predominant symptoms someone has are very frequent bloody diarrhea. Sometimes up to the number of, I think the highest number I saw was 24 bowel movements per day that a patient was having. So it can be very, very significant, the number that someone's having per day. Also, urgency is a big thing. Sometimes they're always rushing to the toilet. They feel like they can't hold it. And unfortunately, incontinence is a side effect in some patients, which is very unfortunate. Tenesmus sometimes happens where someone feels like they have to go to the washroom, but there's actually no stool there to pass. And then other things patients may experience are abdominal cramping, fatigue, potentially a fever if the disease is quite severe, and then loss of appetite. Crohn's disease, many of the symptoms can be similar to the ones just listed for colitis. However, there tends to be not quite as much bleeding just because typically the rectum is spared in Crohn's disease. It can be, impacted, but generally it's spared. So we don't usually see quite as much blood in Crohn's disease. In terms of bowel movement, so I mentioned diarrhea already. I do want to say though that it is possible for someone with IBD to actually have the opposite. So I do see occasionally patients with quite severe constipation who have IBD. However, it tends to be those patients who have more small bowel disease rather than extensive large bowel disease. Other symptoms someone with Crohn's disease might get would be small intestinal like pain and cramping, which can be very, very severe, as well as potentially sores in the mouth and around the anus. And then there is a higher chance of these patients becoming malnourished, and especially in children, this could lead to growth failure. Interestingly enough, so some research is actually showing that although ulcerative colitis is a disease of the colon, small intestinal function and digestion and absorption of nutrients may actually be impacted, likely through communication of neural pathways and potentially inflammatory signaling molecules like cytokines. So I think there's still a lot of research to be done in this area, but kind of an interesting thing to think about. In terms of symptoms, I do want to mention that some patients with IBD can also have IBS on top of their IBD, which can contribute to additional symptoms, so things like gas and bloating. More patients with Crohn's disease seem to have IBS than those patients with ulcerative colitis. And you may wonder, how could someone be diagnosed with both? So generally, if someone with IBD is in a period of remission, especially like endoscopic remission, where there's no visual evidence of inflammation in the body, but they're still having very active symptoms. So say like bloating, cramping, altered bowel movements. At that point in time, they might be diagnosed with IBS if other potential causes have been ruled out, like a gut infection like C. diff. And I think it sounds like you guys have covered IBS previously in another lecture. So I'm not going to touch on too many things related to IBS today. But yeah, I just wanted to point out that some patients can have both. Also, some patients with IBD can have other GI issues like celiac disease, autoimmune diseases, having one autoimmune disease does increase your chance of having another autoimmune disease. So the rates of celiac disease are higher in the IBD population compared to the general population. All right, any questions up until this point?
The chat.
Sorry, what was that?
Questions in the chat.
Oh, sorry, questions in the chat. Oh, sorry, I wasn't looking at that. Oh, sorry, I should back up because there's a number of questions. Let's see. So going back to the fecal calprotectin test. So that actually just measures inflammation in the gut, so not liver function test. So the fecal calprotectin test is a stool test that just measures any inflammation from mouth to anus. And then anemia and high white blood cell counts, they alone cannot be used to diagnose IBD, but sometimes those things are present in IBD. So if someone's having blood work done, say someone comes in having a lot of issues with bowel health, they also have anemia, high white blood cell count, those things might be a sign that they want to, doctor wants to do further investigation to see if there's IBD, because those things can be quite prevalent in the IBD population, but can't be used alone to diagnose IBD. And then, okay, and then, thank you, Moira. And then increased stress levels. So I'm not quite sure what that question was about. Can Jennifer, you clarify that increased stress levels?
Oh, sorry, I was just throwing out ideas when you asked triggers for inflammatory bowel disease. I just thought maybe that could be one of the options.
Thank you. I'm sorry. Yeah, when I ask questions, I guess I should be looking at the chat. I forgot about that. So I'll certainly be doing that the rest of our time together. And then are there certain demographics that make individuals more susceptible to IBD? Other than environmental, certainly genetic predisposition, like I mentioned, if you have family members with IBD, that increases your chance of IBD. And then also gut microbiota, that piece, certainly a lot of things play into your gut microbiota composition, from your diet to physical activity, stress, that impacts things. Antibiotic use, all those things could play into altering the gut microbiota, which could then impact your chance of IBD. And then certainly the dietary things as well. Does that answer those questions, or were there any follow-up questions related to those things? All right, okay, so we'll dive into next talking about potential complications of IBD. So both Crohn's disease and ulcerative colitis can cause what we call EIM, so extra-intestinal manifestations. So these are problems outside of the gut, which can affect things like joints, eyes, skin, muscles, and bones, to name a few. They usually occur during acute flare-ups, and the causes aren't really clear, but are likely related to inflammation in the gut. Cause is actually inflammation is spread throughout the body, as well as potentially an altered immune function response and some genetic susceptibility. There's also an increased risk of colon cancer for colitis and for Crohn's if the Crohn's is in the large intestine. And then an increased risk of lymphoma as a potential medication side effect that some patients with IBD are on. All right, so ulcerative colitis complication. So toxic megacolon is definitely a big concern. Doesn't happen in Crohn's disease, but can happen in colitis. And essentially what this is acute inflammation in the colon causes peristalsis, so things don't move through as well. And when this happens, gas and stool can build up, expand, and then actually can lead to rupture if left untreated, which unfortunately can be life-threatening. I personally have never seen this in my practice so far. I imagine it often sometimes happens like if someone's in hospital and they're admitted for a very severe flare up. Yeah, so far I've never, in the few years I've worked in at our clinic, I've never seen this happen so far, but it can be a potential side effect. For Crohn's disease complications, so one of the most common complications of Crohn's is strict strain disease. And this kind of relates back to that picture I showed you towards the beginning of our presentation. That thickening of the bowel wall can lead to a narrowed lumen, which can be called like stricturine. So there's an area of narrowing in the bowel. And this can make it difficult for food to pass through and may actually potentially lead to an obstruction if the stricture is very severe or if food gets stuck. There are a few different types of strictures. So one is inflammatory stricture. So this is where inflammation causes swelling or edema in the intestinal cells. If someone has this type of stricture, it's possible that they might be able to start on a medication that brings down the inflammation and then their stricture improves. However, the alternative type of stricture, fibrotic strictures, are related to ongoing inflammation and then healing in the bowel, which leads to accumulation of scar tissue. So unfortunately, this type of stricture is not going to be fixed by being on a medication because it's not due to inflammation being present at the time. It's due to kind of that, the inflammation and then healing, which leads to that scar tissue. So medications aren't going to fix that scar tissue. What would fix that scar tissue is potentially surgery or another type of procedure called a stricturoplasty, which I'll cover in a little bit. Another potential complication is an abscess, which is a collection of pus that can become swollen and painful. They're often found in the area around the anus and can potentially lead to fever or fistula if they're left untreated. All right, so next we're going to talk a little bit about fistulas, which are specific to Crohn's. You don't see them in colitis just because, again, Crohn's affects all layers of the bowel wall. And fistulas are tunnels that form between different parts of the intestines or the intestines and another organ. And they can result as from like surgery complications, inflammation, or infections. So this picture you see here is an example of what's called an enterocutaneous perianal fistula. So we can see this tract here running from the anus out towards the skin. So someone might have actually like leakage. They might see stool coming out of a separate hole. That might be one sign that was a fistula. And these are the most common types of fistulas present in Crohn's disease, but you can have fistulas elsewhere in the body as well. And you can see here the names of these different types of fistulas. So it just depends on where the fistula starts and where the fistula ends. I'm not going to go through these things in much detail right now, but just so you know, I guess, fistula, some of the most common ones are between the small and large intestine, enteroenteric, and then the other most common one would be between the intestine and the skin, that enterocutaneous, which we saw on the previous slide here. Unpleasantly, you can actually have them between the intestine and the bladder or the intestine and the vagina. So sometimes patients do have stool coming out of other areas, which can be very significant in terms of symptoms for those patients. So treatment of fistulas, it really depends on the output and the location of the fistula. Sometimes they can be treated with medication and antibiotics, and they might close spontaneously. Other times they might need to be closed surgically. The nutrition plan just depends on where the fistula is and then how high the output is. And so I see a chat. Let me just see. So our abscess is a complication of both IBDs, while fistula is complications of Crohn's. So an abscess is also usually just in Crohn's disease. So both fistulas and abscesses, usually just Crohn's disease. And sometimes an abscess might turn into a fistula if it's left untreated. Okay, so in terms of nutrition management, like I said, it depends on the output of the fistula as well as the location of the fistula. So a low to medium output fistula would be usually considered less than 500 mils per day. If the fistula is high enough in the GI tract, what can sometimes be done to feed the person is that a feeding tube can usually be placed like distally to this fistula, so that the end of the feeding tube is in the jejunum. Either the PEG-J, so going through the stomach, ending in the jejunum, or an NJ, so starting in the nose, going to the jejunum. So we're feeding past the fistula because the fistula is in the upper GI tract and we're feeding below that. If the fistula is low enough in the GI tract, so say the distal ileum or the colon, a patient might be able to keep eating either by mouth orally or have a feeding tube that feeds into the stomach. So PEG going through the stomach or NG going from the nose to the stomach. And they might still be able to absorb enough nutrients without them being significantly impacted. There is kind of an in-between though that's tricky. If a patient has a fistula in the jejunum, if it's not possible to place like a feeding tube past that, like physically, they might not have long enough tubes to go past that, or the patient might not be able to absorb enough nutrients if it's in the very distal jejunum. This patient might need TPN if the fistula is not going to resolve in a short period of time. Then there's high output fistulas. So this is considered if someone has an output of over 500 mils per day, which is a very significant volume. With high output fistulas, I have never seen a patient fed orally with this. They're usually always put NPO, potentially needing TPN if it's going to be a prolonged period of time before it gets fixed, because these patients will lose a lot of electrolytes, proteins, bile salts, pancreatic enzymes, and fluids. So hydration is a big issue for these patients. So I'm just seeing if there's any chats. Okay, so we'll keep going then. So medical treatment, or actually maybe I'll just pause just because that was the end of the fistula section, and just if anyone has any questions, this is a good time to ask anything about fistulas. All right, so we will keep moving then. Sorry, it skipped ahead. So the medical treatment for IBD. So the goals of medical treatment, one would be to reduce symptoms that the patient's getting, which can certainly vary. Reduce inflammation is also another goal. Prevent and correct nutritional deficiencies, and then promote normal growth and development in children. Oh, I'm sorry, I see there's a chat, so I'm just gonna see. So what were the most common types of fistulas? So why don't we just go back to that slide? So one of the most common ones is the enterocutaneous, so going from the intestine to the skin. Primarily, the ones I most see are the ones going from the anus to the skin. And then the other most common type that I've seen is the enteroenteric. So tunnels form between the small and large intestine. And someone might have multiple like tunnels and fistulas. So it might not be just be like one tunnel, it could be multiple tunnels.
I actually have another question related to fistulas quickly.
Sure.
There's time. This might not be related, but I was just wondering if with a high output fistula, since they're losing so many electrolytes, would that also put them kind of at risk for refeeding syndrome? I don't know if that wouldn't.
Yeah, I think it definitely could, especially if like the person has, you would also want to ask about like the the time frame of which their nutrition intake has been impacted. Because these patients, it's usually not just like all of a sudden, like the fistula opens and then they're not eating. It's usually kind of a buildup and progression. Like, often these patients are in really active flare-ups and not feeling very well. So yeah, in addition to losing significant amounts of electrolytes, they might be also really malnourished from weeks leading up to the opening of the fistula. Yeah, that's a good question.
Okay, yeah, thank you.
All right. So in terms of following up with like medical treatment, so those are the goals. Medications, I'm not going to go over these in too much detail right now, just because you can always reference back these slides if you want to look at these in more detail. I just want to point out a few things. So there are different types of classes of drugs used for IBD. Some are more commonly used in Crohn's, where some are more commonly used in colitis, because there are different kind of mechanisms behind these diseases and what medications work to control these diseases. And some patients might start on kind of, less kind of severe medications, or ones that have like, less severe side effects potentially, but then patients might need to cycle through different medications over time because some lose response to medications, particularly biologics, which are used for Crohn's disease. Some patients might start on one, it's working for years, and then all of a sudden they lose response to it. They get inflammation, and then we need to start them on another one. So the body sometimes only responds so long to certain medications, which can be challenging for patients, especially if they're cycling through all the medications that are currently available on the market for their disease. When this happens, they're kind of in an unfortunate situation, and often they might be put on steroids to control like really acute inflammation, or they might be considered for a clinical trial drug. So there are always ongoing clinical trials for drugs that are currently on the market, and some patients will trial these if they've gone through all the other ones that are currently available. Steroids might also be used kind of a bridge a gap if someone's been started on a new medication, but if it might take a while to take effect. So steroids might bridge that gap. And then antibiotics are sometimes used for infections, or in the case of small intestinal bacterial overgrowth. This slide here does go over names of these classes of drugs. You can always reference this if you want some examples of those drugs. There are a few types here listed that I haven't covered already, which I just want to briefly mention. So bile acid binders like cholestyramine are sometimes used if someone's having bile acid diarrhea, which can happen, especially if someone's missing their ileum or part of their ileum, or if the ileum is really inflamed. They might have bile malabsorption, which could lead to diarrhea, which is where cholestyramine might come in handy. Another type of drug that's sometimes used is tricyclic antidepressants, or what we call neuromodulators. So these things are used in a really low dose, way lower than they would be used for mental health reasons. And what they do is they can improve the gut-brain axis and communication without affecting mental health. And they're primarily used in cases of IBS and functional dyspepsia. All right, so if there's no questions at this point, we're going to jump next into surgical interventions for IBD.
I have a question.
Sure.
Yeah, so I was just wondering, with the drugs and medications, are the dietitians responsible for recommending which medications the patient should be taking, or is this the doctor?
Yeah, no, good question. So thankfully, we're not expected to know, which medication a patient should be on. It's primarily the gastroenterologist and the nurses that will take care of that. However, we can give input to the doctors. Input I give in terms of medications would usually be, there was a patient that I saw that had most of his ileum resected. He was having really, really significant diarrhea that wasn't improving with like dietary interventions. And I asked the doctor about the potential to try cholestyramine because I thought maybe he had bile acid diarrhea. And this like changed the patient's life. They actually went from having like 15 bowel movements a day to 1 or 2 bowel movements. So I didn't say to the patient, go ahead and start, but it was something that I brought to the doctor's attention and kind of asked, like, would this be appropriate? Same thing with sometimes antibiotics, so SIBO. Sometimes, based on my assessment of patients, I might suspect that maybe this patient has SIBO, that it might be worthwhile trying an antibiotic, and that would be something I'd ask the doctor about. Same with things like tricyclic antidepressants. Those would be something I might ask the doctor about if we're exploring dietary things for IBS with the patient, but dietary things aren't working. That might be something that I could ask the doctor about. But thankfully, you don't need to know about these drugs in detail, but it can help to be a little bit familiar with them in case, when you're working with a patient, you suspect that something like one of these medications might be helpful in conjunction with your dietary recommendations.
Thank you.
No worries. All right, so for ulcerative colitis surgeries, so one of the main types of surgeries that could be done for very severe ulcerative colitis is called a proctocolectomy. And this is where the colon and the rectum are removed. And what's formed after that surgery is a J pouch, or called an ileoanal pouch, or potentially an end ileostomy. Whether someone gets a J pouch or an end ileostomy really just depends on their like medical and health history. There's certain things like if they've had like pelvic floor surgery before, they might not be eligible for a J pouch surgery. If they're like an elderly person, they might tend to do an ostomy more. So it just depends on individual factors. The surgery is either usually done in 2 or 3 stages that are actually usually like quite spaced out. They're not done like right after the other to really give the bowel like time to kind of adjust to functioning better. And if it's done in 3 surgeries, the first step of this surgery is a colectomy with creation of an end ileostomy, and then the rectum's actually left in place. So unfortunately, this image you can't see on the right there. The images only show like the second and third step, but to help you visualize that, so most of the colons are moved. The end part of the ileum is brought to the skin, so that waste can exit throughout through the ileostomy. And then the rectum is left in place for now, which is a bit confusing, but we actually need that left there because we can't just have the anus left on its own in the bowel. We need the rectum attached to it for the health of the tissue because we need the anus for like the second step of the procedure. So someone might have an endoileostomy for a number of months, and then in the second stage of the surgery, what happens is that rectum is removed. And then the ileum is turned into a pouch and connected to the anus, and then diverting ileostomy is created. So I'll show you in this picture here what happens. So what the patient had before this second stage was this piece would have been going out to the skin as the end ileostomy. But with this procedure, that was taken down, and then this ileum is turned into a J pouch. So we see that J shape there. That's what's called the J pouch or the ileoanal pouch. And this pouch is connected to the anus, which is that kind of green-brown piece of tissue there. So waste would actually be exiting throughout the anus normally. This pouch kind of acts as a reservoir to hold the bowel, hold the stool until the patient's ready to pass it through the anus. And then this is the diverting ileostomy. So a piece of ileum is brought to the skin for waste to be temporarily exited through the body as that diverting ileostomy. This is done just to allow this J pouch to heal enough and to function properly. If you didn't do this indeterminate or intermediate step, then this wouldn't be healed enough to function well. The final procedure is this is taken down, this diverting ileostomy. You don't need it anymore, so it's taken away, and then food does go normally through the GI tract into the J pouch and then out through the anus. If it's just done in 2 steps of surgery, the first and the second step are done in one surgery, and then this last step is done in a second surgery. I do actually have a few comments about this surgery. So one, I mentioned earlier in terms of like, can IBD be cured? That there was kind of a caveat to this straight answer of no. So this procedure, proctocolectomy, is generally considered curative for ulcerative colitis. However, some patients can still have complications with a J pouch. So in some patients, what could happen is there's something called pouchitis, an inflammation of this pouch that can become inflamed. Also, something can happen called cuffitis, where so right here, there's a tiny cuff or ring of rectum that's left behind so that the ileum can be attached to the anus. This little cuff could become inflamed, so something called cuffitis. Another thing that could happen other than pouchitis and cuffitis are that sometimes what happens in patients is they might end up having small bowel symptoms, which could happen if someone actually had Crohn's, but they're diagnosed with colitis. Crohn's patients do not do well with a J pouch. It normally tends to bring out their disease very severely. So if someone gets a J pouch and actually has Crohn's, this might bring out their Crohn's disease in their small intestine, which is very unfortunate. Any questions about that procedure at all? Okay, and then I do also want to mention about the ulcerative colitis. Some people will wonder about like why couldn't just part of the colon be resected, like the disease part, and then a colostomy be created rather than like taking out the whole colon if the whole colon's not inflamed. So some of our gastroenterologists said they don't remove just usually parts of the colon. Because what happens is even if they just remove part of it, usually the colitis comes back in the other part of the colon. So then they'd have to go do an additional surgery. So they usually just remove the whole thing. They don't just remove parts of the colon. Okay, so just to confirm, these surgeries are done in ulcerative colitis and not in Crohn's patients. Yeah, so this surgery is done for colitis only. Colitis, like typically, I've never seen our doctors do it for someone that I know who has Crohn's disease. I think in the States, I've heard of that happening sometimes, but this surgery in Crohn's patients tends to bring out their disease in their small intestine very significantly. So it's usually only reserved for patients with colitis. What could happen though is someone's diagnosed with colitis and then they get this J pouch and then it actually turns out that they have Crohn's disease. So that was a misdiagnosis. Generally, they only do the surgery if they for patients that they think have only ulcerative colitis. All right, so next moving on to Crohn's disease surgeries. So fistula removal is one potential surgery that someone might need if they have fistulas. If they have abscesses, they might need those to be drained or given antibiotics. If someone has structuring disease, sometimes these might need to be resected, but sometimes a procedure can be done without the need for resection, and this is called a structuroplasty. And essentially you can see that there's an incision made along here. The bowel is pushed together to widen that lumen and then it's sewn up so that there's not that narrowed section of the bowel here. Another surgery that's sometimes done in Crohn's disease is a total colectomy. This is where the colon's removed, rectum's left in place. So this will be done if someone just has extensive disease in the colon, but the rectum is spared. There's no active inflammation in the rectum. If this is done, the ileum can either be connected to the rectum because the rectum's still there, or the ileum could be formed into an end ileostomy and just the rectal stump is left in place. It's a bit confusing, like why would there be like the rectum left in place if you're not using it and you have the ileostomy? But why that's sometimes done is sometimes the patient's not ready to have it reconnected, but they might eventually want to have it reconnected. So with it being left in place, years down the road, potentially a patient might want to have the ileum connected to the rectum so that they can pass waste through their anus rather than having an external ileostomy. Another surgery that might be done is a proctocolectomy. So alternative to a total colectomy, in a proctocolectomy, the colon and the rectum are removed. So there is an end ileostomy. You don't have the option of connecting the ileum to the rectum because there is no rectum that's been removed. And then another surgery could be a partial colectomy. So this is also known as a subtotal colectomy, where only part of the colons are moved. Either could be just the right side or just the left side. And if it's either or, it could be called a hemicolectomy. Okay, and removal of the colon, whether it's a partial removal of the colon or full removal, is sometimes also done for if someone has things like colon cancer, diverticulitis, bleeding, fistulas, bowel obstruction, toxic megacolon, necrotizing enterocolitis, or extreme constipation. And I'm just curious, so I've mentioned in Crohn's disease, you can sometimes just resect pieces of the colon rather than the whole colon. Does anyone have any idea why you can remove just pieces of the colon instead of having to remove sometimes the whole thing? Tissue regeneration. So I guess in terms of tissue regeneration, I mean, it's possible that parts that aren't resected could, I guess, function better, make up for the pieces of resected tissue. The main reason would be though that in Crohn's disease, that there are usually pieces of like healthy tissue next to pieces of diseased tissue. So you can remove the piece of diseased tissue and stitch together the pieces of healthy tissue on either side to reconnect those. So Crohn's disease, you can often see someone getting it sometimes like going back for multiple surgeries, and they might get, just a piece resected, and then a few years later, need another piece resected. And so they might have a more extensive surgical history than someone with ulcerative colitis. All right, so that kind of covers the surgeries for IBD. Any questions about that before we move on?
I just wanted to confirm, like, what would be considered like normal bowels after surgery like this. So basically, like, the higher up a resection is, or like the more bowel that's removed, you would just have like more watery, like less formed stool. Is that right?
I guess it just depends on like where the resection is. Especially if someone has like a lot of colon removed. So, the colon is the primary place of the amount of like water being reabsorbed. So if someone's had a lot of colon removed, chances are they're going to have a lot more watery output. Someone who's had like pieces of small intestine resected, their bowel function may or may not change that much, as it just depends on like how much is resected. Some patients I actually find that, so say they might have like severe like constipation and issues if they have stricture disease, but once that's removed, the strictured area, they might have more normal bowel movements. But then I guess if someone has a lot of small bowel removed, if that then leads to like short bowel syndrome, that could lead to a lot of like loose, like high output. So for some patients, it does improve output or bowel frequency after surgery. Others, it might temporarily be worse after surgery.
Okay, thank you.
Okay, no worries. Sorry, I hope you don't hear the crying too much. My son's going down for a nap in the background, but hopefully he'll be down soon. Okay, so we're just going to next touch on general surgery preparation. So we're going to talk a little bit about traditional approaches to pre and post-op recovery, as well as kind of a more modern approach to surgery management. So kind of a traditional pre-op approach to prepping for surgery, like bowel surgery for a patient, would be to be on clear fluids a day prior to surgery, and then mechanical bowel prep the night before. So some type of laxative with the goal of having a completely empty GI tract for surgery. These patients are made NPO at midnight typically, and then sometimes if they're on TPN, that might be able to be continued even sometimes like during the surgery, just depending on the gastroenterologist. All right, so traditional post-operative protocol would be that a patient is often made NPO, sometimes for even up to a few days, with or without an NG tube for aspirating stomach contents. So sometimes if the stomach contents are building up and they're not moving through well, an NG tube is put in place to suction those contents out. So in hospital, when I first started working in hospital, I was a bit confused about this. Sometimes I'd see a patient with an NG tube and assume, oh, this patient's being on tube feeds. But just, like NG tubes aren't necessarily being used for tube feeds. They could be used for just aspirating stomach contents, not for feeding. And then traditional approach, patients might be slowly progressed to more regular foods. So put NPO, then clear fluids and full fluids, and then put on small meals, sometimes often like low fiber meals. And the idea behind this really slow progression is to try to wait until the bowel function has like fully resumed before advancing the diet. However, that's not like based on like current actual evidence. There isn't evidence that you actually like need to wait until there's evidence of like bowel sounds or anything before actually implementing food. So that's more of a traditional old-fashioned approach to it. More often than not, you'll see in hospital something called the ERAS, the Enhanced Recovery After Surgery Pre-Op Protocol. So with this protocol, instead of being NPO at midnight, patients are typically the day leading up to surgery taking in a lot of carbs to build up the reserves, and then they're allowed clear fluids actually up to 2 hours prior to surgery. The purpose of allowing this rather than being NPO for a prolonged period would be to minimize that fasting period and to prevent them going into the surgery malnourished, and to give them more carbohydrate stores to help them have better outcomes in the surgery. A traditional post-op protocol, or sorry, not traditional, the ERAS, so advanced a recovery after surgery post-op protocol, would be clear fluids right after surgery instead of being NPO, and then advancing to the diet as soon as possible. So diet is actually advanced quite quickly, usually to full fluids and then DAT as soon as possible, not necessarily low fiber, only if that's indicated. And then there are other also elements to the ERAS protocol, like gum chewing. So the physical motion of chewing gum stimulates that bowel to get moving. One tip you see at the bottom there is if someone's on clear fluids, you could order something called the Boost fruit beverage. So it is a clear beverage that's going to be allowed on clear fluids, but it has added protein in it. So a little more, gives them a little more nutritionally than just a regular juice. Something else that actually Nestle has like just recently come out with is a product called Boost Soothe, which is also a clear fluid, high protein drink. So that's another option that you could order. And it's actually also an option that you could order if a patient's on clear fluids before bowel surgery or a scope. The reason why I want to mention this is because oftentimes those patients aren't allowed to be having like oranges, reds, and purples, purple drinks, because it could look like blood in their GI tract at the time of a scope or surgery. So this Boost Soothe being clear would be allowed, even if they're not allowed those colored drinks. That could be an option to look at if you're in hospital looking for a clear, higher protein drink for a patient. And this is just a visual to see what this protocol might look like in the chart in a hospital. All right, so that is the kind of just a snippet of the pre and post-op protocols. Any questions about that before moving on to nutrition assessment for IBD? All right, okay, so we'll dive into nutrition assessment then. So the ABCDs, there are certainly many different factors and things that we want to look at when we see a patient with IBD. So for anthropometrics, certainly we do want to be asking about weight history. A lot of these patients have quite significant weight loss, especially if they're in very active flare-ups. More so I see significant weight loss in Crohn's rather than colitis, but certainly could happen in either or. Biochemical tests, we already talked about some of those lab tests already, but just to reiterate, anemia can be very common, especially iron deficiency anemia. But you can actually also have anemia of chronic disease on top of iron deficiency anemia. So something to keep in mind because it does impact how you interpret ferritin readings. So just, something to be mindful of. Clinical symptoms, we already talked about some of the symptoms that someone could have with Crohn's disease. Certainly there are many, many different symptoms they could have. And then nutrition history and client history, you definitely want to be asking in detail about symptoms and bowel habits. So whether they're having any bloating, pain, nausea, vomiting, their bowel habits, and then in detail about their eating patterns, whether they're what they're eating, if they're avoiding anything, if they have any allergies or known food triggers. Some of the most common diagnoses for IBD patients would be inadequate intake. Many factors often play into inadequate intake, some being a low appetite, nausea, really low energy, or they're just afraid of eating because they don't want to have more bowel movements or more GI symptoms. Altered GI function is also another common nutrition diagnosis used, which could be related to extensive losses, so from bleeding or diarrhea, potentially protein losing enteropathy, or bacterial overgrowth, so SIBO. Underweight, unintended weight loss, those are also pretty common. Impaired nutrient utilization. So some drugs can impact how someone metabolizes different nutrients. So as an example, methotrexate and sulfasalazine, which are two drugs used for IBD, can impact how folate is metabolized. So these patients will need to be on folic acid supplements. Some patients also have increased protein and sometimes increased energy needs, which we're going to talk about a little bit next. So I found this a bit surprising when I started working in this field, but for most patients, resting energy expenditure is actually not usually higher in states of flare-up. It's usually the same in flare-ups compared to remission, as IBD doesn't cause hypermetabolism. And your energy requirements are actually usually only generally raised if someone has a very acute flare-up in which there is fever, fast heart rate, and if they have sepsis or infections. But usually, even if this is the case, oftentimes these patients aren't as physically active. So this kind of compensates for that, and their total energy expenditure might actually be around the same as in remission still. So generally, standard predictive equations are appropriate for this population, like the Harris-Benedict equation. That's the one that I most commonly use. Except for patients who have a very high BMI, then I might use the Mifflin-St. Jeor equation. Some considerations though, so I did mention, resting energy expenditure is usually not higher, but you do have to consider how much is getting absorbed as well as how much the patient's losing. So for absorption, if someone has a lot of their small intestine missing, they're certainly not going to be absorbing all of what they're taking in. So they might need to be eating more to compensate for that. Alternatively, if they have very high outputs, if things are moving through really fast, if they have large outputs of diarrhea and fistula output, again, they might need to be eating more energy to compensate for the losses. So short chain fatty acids, or SCFAs, these are also something to keep in mind. They're produced in the colon when bacteria ferment fiber, and they can actually be quite a significant energy source, actually even providing up to around like 500 to 1,000 calories per day. A large portion of these calories that would be used by the colon cells themselves, they wouldn't be getting absorbed for the rest of the body to use. But around usually 10% of the daily caloric requirement of an individual is short chain fatty acids that are absorbed into the bloodstream and utilized by the rest of the body. So if someone's missing their colon, they're not going to be producing these short chain fatty acids, and they won't be getting that extra energy related to the fermentation of the fiber. All right, so for protein, so even though energy requirements aren't usually raised during times of inflammation, protein requirements are. So when someone's in remission, usually protein needs are around 1 gram of protein per kilogram of body weight, whereas in flare-up, they're around 1.2 to 1.5 grams of protein per kilogram of body weight per day. But certainly, again, you kind of have to take into account individual factors, whether this is the correct range for the patient. So just like with energy needs, we have to consider like how much the patient's absorbing and how much they're losing. Other than those things, I'm just wondering, does anyone have a few ideas about like other things that might impact someone's protein needs or the recommendations for protein that you give? So I guess, there are certainly lots of different potential factors. So one thing to consider is physical activity. So, that can also impact energy requirements and as well as protein requirements. If someone's very physically active, you might need to go higher than this range of 1.2 to 1.5 grams of protein. I generally don't find patients, if they're in a flare up, they're not usually up for doing a lot of physical activity, but it's possible that they might be feeling well, even though they're having a lot of inflammation. Other things to consider would be if someone has other comorbidities, so things like chronic kidney disease, you might need to kind of modify protein needs. Maybe you can't go quite as high in that case. Or someone has wounds, you might even need to go higher than the 1.2 to 1.5 grams of protein per kilogram body weight. All right, so I'm just wondering, Heather, we're kind of moving into a new section here of like the dietary recommendations for IBD. Should I get going on this, or should we pause for today and carry on for the next lecture?
It's up to you. I think we have about 5 minutes left. So I'm not sure. I haven't looked through your slides to kind of see how long this section is, or whether this is kind of an ideal breaking point, or you want to just kind of maximize time and use it so that you have more time in next lecture. But whatever you like to do, Gina, is okay.
Well, maybe we'll just get going into it, because I think we have a fair bit to cover next lecture. So we may as well utilize this time now. So yeah, we'll just start talking about dietary recommendations and then carry on next week as well. So let's see. So I'm just seeing my notes where we're at. So first of all, we're going to be covering nutrition recommendations that are given to patients, often both in times of flare up and remission. So these aren't specific to remission or flare up. It's just kind of general recommendations and things that we look at in patients' diets. These recommendations are certainly like individualized though, based on the person's, medical and nutrition needs. So we would take those things into account. But one thing that is common that dietitians discuss with IBD patients is ensuring the diet is nutritionally adequate. Many things can make a patient more at risk of deficiencies. So including if they have a decreased intake, if they have low appetite, or a fear of making their symptoms worse. Restrictive diets are very common in the IBD community, and we'll be touching on some of the most common types of diets in a little bit, but those can significantly impact what someone is taking in nutritionally. Surgical resections, those make someone more susceptible to deficiencies, which we'll touch on in a little bit, some of the most common types of deficiencies in IBD. Extensive losses can play into things as well as medication. So I gave you some of those examples like methotrexate, sulfasalazine, some things like that can impact metabolism of certain micronutrients. So those were impacting folic acid. Other common things that we discuss with patients, both in times of flare-ups and remission, are things like trying to chew your food really well, eating slowly, as digestion does start in the mouth. And then pace of eating really impacts how well someone is able to how well someone can digest their food. Something else to be mindful of is that most patients find it helpful to have small, frequent meals throughout the day rather than like large meals that are spaced out. However, some patients swear by intermittent fasting. It's kind of a very trendy thing, not only in like, the weight loss or community or like other types of diet or for other reasons, but IBD, I do find a lot of patients are very interested in intermittent fasting and how it would impact their GI symptoms. I do find that most patients, although some swear by it, most patients don't do well with that eating pattern though, because it's large meals usually that are very, very like spaced out. I usually find patients do better with smaller amounts of food at one time. Eating in a relaxed environment is very important. Be mindful of stress, as the state of mind in someone's the physical state of mind, I guess, does impact how their body can digest food through that brain-gut interaction. Really important fluid intake, especially if someone has high output. So drinking an adequate amount of fluid and also appropriate types of fluids. We will dive quite a bit more into talking about types of fluids when we cover short bowel syndrome. So stay tuned for those details next week. And then a few other things that we often go over with patients are potentially needing to modify or limit intake of really spicy, fatty, and sugary foods, especially if they're impacting someone's symptoms and bowel movements. And then aiming for balanced meals. So not specific to IBD, I think that's a general thing that we discuss with patients, but that is definitely a focus for me in clinic with a lot of the patients I see, ensuring, even if they're having to limit certain types of foods or on certain types of diets, ensuring that nutritionally they're getting balanced meals and all the different nutrients that they need, or if not, thinking about what they might need to be supplementing in their diet with nutrition supplements from different medications. All right, so I think we'll stop here for now, and next week we'll continue on with talking about this. Next week, we'll start with talking about during flare-ups. What are some more specific recommendations during times of flare-up? I think you've talked a little bit about diarrhea and constipation already, so it might be some overlap with things you've learned before, but hopefully good review for you all, and there might be some new things as well for you to learn. So any questions? I think we're at 10:20 right now, but any quick questions before we wrap up for the day?
I was just wondering about fiber. Like, would fiber be just like the normal recommendations in between flare-ups?
Yeah, so typically, as long as someone can tolerate fiber, usually if someone's feeling well, there's no need to limit fiber. They can usually have both insoluble and soluble fiber. And it might actually be helpful for them, especially in terms of the composition of their gut microbiome. Having enough fiber might produce a more ideal balance of like gut bacteria, which could potentially significantly, benefit their disease. The one exception I will say, I guess a few exceptions. So if patients with Crohn's disease have strictures, because it's possible to have, those fibrotic strictures even in times of remission. If a patient has significant narrowing in their bowel, they will need to be mindful of their fiber intake, particularly insoluble fiber. So not having a lot of peels, skins, whole nuts and seeds, whole grains, that is something they need to modify even in times of remission. Also, I guess if someone's in remission, it's possible that they're still having altered bowel movements, especially if they have IBS. So some patients, even if there's no inflammation, might be having a lot of like loose, frequent bowel movements. And in that case, they might need to try to have more like soluble fiber and less insoluble fiber. If someone's feeling well, they don't have strictures, they have fine bowel movement, certainly there's no contraindication to fiber intake, and it's generally, recommendations would be similar to the general population in terms of amounts of fiber needed.
Okay, great. Thank you so much.
Of course. Any other questions today? All right. Well, yeah, I think we'll wrap up there then. And thanks all for your attention. And I look forward to chatting again with you